Friends, this is an intumescent cataract. Let us observe the surgical steps. This is the main incision, 2.8 mm. This is a posterior limbal incision. And now, this is one side port on the right side of the main incision. Now I am going to inject air bubble, and underneath this air bubble I am going to inject trypan blue dye to stain the anterior capsule of this white intumescent cataract. The dye has been applied, and after a few seconds the dye is washed out. That's it. The dye has been washed out. A nice staining has occurred, and now viscoelastic substance is injected into the anterior chamber. This is Viscoat from Alcon, and this is SPMC underneath Viscoat. So this is a modified soft shell technique. This is one more side port on the left side of the main incision. Now I am going to do Capsulorhexis. The anticapsule is incised with a 26 gauge bent cystitome. Then I take a utrata forceps and I move anti-clockwise and make a very small rhexis on the anterior pole of this cataractous lens. I call it a mini rhexis. And now, to decrease intralenticular pressure, I am aspirating some cortical lens matter. This is a Simcoe cannula. You can use bimanual IA or coaxial IA to remove some cortical lens matter through this small opening, and thus you can drastically reduce the intralenticular pressure. Once the intralenticular pressure is reduced, the tendency of the capsule to run out beneath the iris towards the equator is no more, and the shrew is tamed. So this is done. This surgery has become a very simple one just by aspirating some cortical lens matter. This is a small nick at around 7:30 o'clock. Now I hold this capsule here and enlarge the rhexis to an optimum size. That's it. So utrata forceps is very good in intumescent cataracts. I encourage youngsters to learn to use utrata forceps in many cases. Now this is direct chop. Hold the nucleus with high vacuum and chop it. This nucleus is brittle and it is getting chopped very easily. This is Oatley Cataract 3 Phaco machine. Vacuum is 450 and flow rate is 45, and power used in this case is only 60%. That's it. The nucleus has been managed. Now I'm going to remove some cortical matter, and I can see there is a fibrous sheet over the posterior capsule which cannot be polished out, and this is hydro polish to remove the loose cells sticking beyond this fibrous mat. And now peripheral cortical fibers are being removed by the Simcoe cannula. So the surgery is done. We just have to implant an intraocular lens in this case. This is a hydrophilic acrylic intraocular lens being implanted under irrigating fluid. The left hand irrigating probe guides the trailing haptic to go into the capsular bag. That's it. The surgery is done. We just have to hydrate the side ports. This is intracameral pilocarpine. This is intracameral moxifloxacin. And now the side ports are hydrated with BSS. And a final wash is given to remove the pilocarpine and moxifloxacin molecules. I have followed up this case and the patient is doing very well. On the operating table itself, I have counseled the patient that he may have to undergo YAG laser capsulotomy. Thank you very much for watching. Hope this video will help you in developing your surgical skills.